doctors. I believe your preparation for EDIC Part 1 is going on well. So today, let's kick in for new set of questions.
Question 1. A 56-year-old man with septic shock is mechanically ventilated. His ABG shows partial pressure of CO2 48 mm of mercury, while EtCO2 is 28 mm of mercury. Which of the following best explains the widened partial pressure of CO2 EtCO2 gradient? Hypoventilation due to increased airway resistance. B. Low cardiac output state with increased dead space ventilation. C. Leak around the endotracheal tube cuff. D. Increased metabolic CO2 production. E. Excessive sedation leading to hypoventilation. Correct answer is B. Low cardiac output state with increased dead space ventilation. Explanation. Normally, partial pressure of CO2 EtCO2 difference is 2 to 5 mm of mercury. In low cardiac output states, alveolar dead space rises, widening the gradient. Hypoventilation or sedation raises both partial pressure of CO2 and EtCO2 proportionally. Question 2. In a ventilated septic shock patient, PR increases stroke volume index by 15%, pulse contour. Which interpretation is most evidence-based? Patient is preload dependent and will likely respond to fluids. B. PR is unreliable with high PEEP greater than 10 cm of water. C. Preload reserve is exhausted and fluids should be avoided. CVP change greater than or equal to 2 mm of mercury must be present for PLR to be valid. PR is only valid in spontaneously breathing patients. Correct answer is A. Patient is preload dependent and will likely respond to fluids. Explanation. PLR predicts fluid responsiveness if cardiac output or stroke volume rises greater than or equal to 10%, independent of ventilation mode or CVP. Question 3. In ARDS, plateau pressure is 32 cm of water, PEEP 10 cm of water, tidal volume 6 ml per kg predicted body weight. Which measurement best distinguishes chest wall restriction from lung overdistension? Peak inspiratory pressure. B. Driving pressure, plateau pressure minus PEEP. C. Transpulmonary pressure with esophageal manometry. Static compliance, tidal volume divided by plateau pressure. Airway resistance calculated from peak pressure minus plateau pressure. Correct answer is C. Transpulmonary pressure with esophageal manometry. Explanation. High plateau pressure may reflect stiff chest wall or true alveolar overdistension. Transpulmonary pressure clarifies actual lung stress. Question 4. In a septic shock patient, arterial line tracing is overdamped. Slurred upstroke, low systolic, high diastolic, MAP 65 mm of mercury. Which is correct? Option A. Hypotension is real and requires fluid bolus. B. Overdamping underestimates systolic, overestimates diastolic, MAP remains reliable. C. Overdamping falsely elevates systolic pressure. D. The arterial catheter should be removed immediately. Option E. Arterial line waveform damping does not affect any value. Correct answer is B. Overdamping underestimates systolic, overestimates diastolic, MAP remains reliable. Explanation. Despite distorted systolic and diastolic values, MAP remains accurate and useful for resuscitation. Question 5. A ventilated patient in shock has IVC diameter 2.5 cm, less than 10% variability, left ventricular outflow tract VTI 12 cm with no rise after fluids. Which interpretation is correct? Patient is preload responsive, needs more fluids. B. Patient is volume overloaded, avoid further fluids. C. IVC assessment is unreliable in ventilated patients. D. IVC findings contradict LVOT data, ignore both. High IVC diameter always indicates tamponade physiology. Correct answer is B. Patient is volume overloaded, avoid further fluids. Explanation. Non-collapsible dilated IVC plus no VTI increase equals no fluid responsiveness. Fluids will not improve cardiac output. Question 6. A septic shock patient has CVP 14 millimeters of mercury, yet PLR and pulse pressure variations suggest fluid responsiveness, which is most evidence-based. CVP greater than 12 millimeters of mercury proves preload sufficiency. B. CVP interpretation requires accounting for intrathoracic pressure and venous compliance. C. CVP reliably predicts fluid responsiveness in ventilated patients. D. High CVP always contraindicates fluids. CVP should be ignored completely in modern practice. Correct answer is B. CVP interpretation requires accounting for intrathoracic pressure and venous compliance. Explanation: CVP reflects right atrial pressure but poorly predicts fluid responsiveness. Dynamic indices, PLR, pulse pressure variation, stroke volume changes, are superior. CVP may help in context, for example, RV failure, tamponade, cannot be ignored completely. Question 7. A 45-year-old trauma patient arrives in the emergency department. His heart rate is 120 beats per minute and systolic blood pressure is 90 millimeters of mercury. The shock index, SI, is calculated as heart rate divided by systolic blood pressure. Which statement is most evidence-based regarding the use of SI in critically ill patients? Index greater than 0.7 is normal in young healthy individuals. B. Index 1 predicts increased mortality and need for massive transfusion in trauma. C. Index is unreliable in septic patients due to vasodilation. D. Index is superior to lactate in predicting outcome in shock. Index is only valid in spontaneously breathing patients, not ventilated ones. Correct answer is B. SI-1 predicts increased mortality and need for massive transfusion in trauma. Explanation: shock index is normally 0.5 to 0.7. SI greater than 0.9 is an early marker of hemodynamic instability. SI-1 in trauma correlates with higher mortality, greater transfusion requirements, and ICU admission. It complements but does not replace lactate. Valid across septic and trauma cohorts, independent of ventilation. Question 8. A septic patient with hypoxemia is being monitored with pulse oximetry. The SpO2 is persistently 88% despite FiO2 0.6. Which of the following best describes limitations of pulse oximetry in this setting? Overestimation of saturation in carbon monoxide poisoning due to absorption overlap. B. Underestimation of saturation in methemoglobinemia due to dual absorption peaks. C. Delay in detecting hypoxemia due to averaging algorithms. D. Accuracy declines when SpO2 less than 90% and in poor perfusion states. All of the above. Correct answer is E. All of the above. Explanation: pulse oximetry uses two wavelength spectrophotometry, 660 and 940 nanometers. Carboxyhemoglobin causes overestimation, methemoglobin causes SpO2 85% regardless of true saturation. Low perfusion, movement, and low SpO2, less than 90%, reduce accuracy. Built-in averaging causes delay in rapidly changing hypoxemia. Question 9. In the ICU, a patient with severe traumatic brain injury is monitored with ICP, intracranial pressure, CPP, cerebral perfusion pressure, SjVO2, and brain tissue oxygen, PbTO2. Which multimodal monitoring interpretation is most correct? CPP should be universally maintained greater than 90 millimeters of mercury for optimal outcome. Low SjVO2, less than 50%, indicates global cerebral hypoperfusion and risk of ischemia. C. PbTO2 greater than 10 millimeters of mercury always guarantees adequate cerebral oxygen delivery. D. ICP monitoring alone is sufficient to prevent secondary brain injury. Multimodal monitoring has no role in individualizing therapy in TBI. Correct answer is B. Low SjVO2, less than 50%, indicates global cerebral hypoperfusion and risk of ischemia. Explanation: ICP and CPP guide pressure targets, but oxygenation monitoring adds metabolic data. SjVO2 less than 50% suggests inadequate cerebral blood flow. PbTO2 less than 20 millimeters of mercury is concerning but must be interpreted with CPP and autoregulation. Guidelines recommend individualized multimodal monitoring to optimize outcomes rather than rigid universal CPP targets. Question 10. A 60-year-old patient post-laparotomy develops oliguria and increased peak airway pressures. Bladder pressure measurement shows intra-abdominal pressure, IAP, 22 millimeters of mercury. Which interpretation is correct? IAP greater than 12 millimeters of mercury defines abdominal compartment syndrome. B. EAP greater than 20 millimeters of mercury with new organ dysfunction defines abdominal compartment syndrome. C. EAP is best measured directly via intraperitoneal catheter. D. Intra-abdominal hypertension does not affect hemodynamics in ventilated patients. E. IAP monitoring is unreliable and not recommended in ICU practice. Correct answer is B. EAP greater than 20 millimeters of mercury with new organ dysfunction defines abdominal compartment syndrome. Explanation. World Society of Abdominal Compartment Syndrome defines intra-abdominal hypertension, IAH, as IAP greater than 12 millimeters of mercury. Abdominal compartment syndrome is IAP greater than 20 millimeters of mercury plus evidence of new organ dysfunction, for example, oliguria, airway pressures, cardiac output. Measurement is usually indirect via bladder pressure, gold standard. IH impacts renal, cardiovascular, and respiratory systems. Question 11. A 62-year-old COPD patient has been ventilated for 7 days due to pneumonia. During a spontaneous breathing trial with T-piece, his respiratory rate is 32 breaths per minute and tidal volume is 250 milliliters. Which statement regarding the Rapid Shallow Breathing Index, RSBI, is most correct? A. RSBI is calculated as tidal volume divided by respiratory rate. B. RSBI less than 105 breaths per minute per liter predicts a high likelihood of successful extubation. C. RSBI has 100% specificity but poor sensitivity in predicting weaning success. D. RSBI should be measured during pressure support of 15 cm of water to optimize accuracy. A low RSBI guarantees successful extubation without risk of failure. Correct answer is B. RSBI less than 105 breaths per minute per liter predicts a high likelihood of successful extubation. Explanation. RSBI equals respiratory rate divided by tidal volume in liters. In this patient, respiratory rate equals 32, tidal volume equals 0.25 liter, RSBI equals 32 divided by 0.25 is equal to 128 breaths per minute per liter, above cutoff. RSBI less than 105 has good sensitivity, 80%, and specificity, 70%, for predicting successful weaning. It should be measured during minimal support, T-piece or very low pressure support. A low RSBI improves chances but does not guarantee success, as extubation depends on multiple factors: secretion clearance, airway protection, mental status.
Dear doctors, I believe these questions were useful to you.